Good morning, everyone. Welcome to our webinar, Developing and Growing Sustainable Telehealth Programs. We appreciate you spending part of your morning with us. We have a great session planned for you. So before we start, I'll quickly go over a few items. Everyone is muted today, but if you have a question, you may submit it into the chat or into the Q&A portal, which is located on the bottom right corner of your screen. We are also recording today's webinar, and you will receive a link to the recording in a follow-up email, and the recording will be available on our website. We have two excellent and accomplished speakers today. Mary Zelazny is the CEO of Finger Lakes Community Health Center. She has focused much of FLCH's work on the integration of health information technology within the organization, including the development and operation of the Finger Lakes Telehealth Network. FLCH is now a nationally recognized leader in the implementation and use of telehealth, connecting a wide variety of healthcare providers through technology to provide more access to care for patients. Dr. Andrew Talal is currently a professor of medicine at SUNY Buffalo. He is the principal investigator on a 5-year award from the Patient-Centered Outcomes Research Institute to study telemedicine-based HCV treatment among patients on methadone. He is also the chair of the New York State Telehealth Work Group, with the objective of increasing access to telehealth as an option for HCV treatment among persons with opioid use disorder. Also joining us are Sandeep Krishnan, CEO of MedTech Interlinks, and Mike Connolly, Senior Account Manager at Aspire. Sandeep will moderate Mary's and Dr. Talal's presentation. Mike will provide a brief overview of Aspire Technology Partners. And with that said, I will now turn things over to Mike Connolly. Mike?
Good morning, all. Thank you very much for your interest in attending this very, very valuable session. For over 15 years, Aspire has specialized in delivering digital infrastructure solutions and managed services to help our clients achieve their business goals. We take time to understand the business initiatives, and we align our solutions to achieve the desired outcomes. Our experts design healthcare solutions securely to connect patients, doctors, process, and improve access and boost quality care and maximize efficiency. All done considering regulatory requirements at a state and federal level. We have great customer success outcomes, and our customer success team helps customers realize the continuous value from their technology investments. We will learn today the importance of aligning the business outcomes before selecting technology, and Aspire has recognized the benefit of aligning with ecosystem partners like MedTech Interlink to provide a full life cycle solution for our clients. We're very excited to get into a real life experience from our first presenter, Mary Zelazny, and with that, I will introduce Mary for our comments. Thank you.
Thanks, Mike. I really appreciate the opportunity. Hello, everybody. I'm really glad to be here, and I want to talk to you a little bit about our journey with telehealth as a federally qualified health center. We have, my slides wanted, there we go. So let me just give you a little background on who we are and then what we did with telehealth. So we're a health center program, community health center program. I'm sure you've heard of our model of care. We see about 29,000 patients across the Finger Lakes region, which is a rural area of New York State, western central New York State. We have 8 smaller sites that go from up by Lake Ontario down to the Pennsylvania border. So we're pretty spread out, and it is rural, and we have Finger Lakes. There's 11 of them actually, that, you know, there's no bridges across those lakes. So we really need to understand how we can provide care to our patients effectively, right? So this is just a map to show you ballpark where we are. It's a beautiful part of the country, but it is rural, and we are very challenged with geography. So, one of the things that I want to start out to talk about is, why did we choose telehealth as a way to help provide better care for our patients? We have all the same issues that any health system has: access to providers, workforce shortages. How do we provide care effectively? How do we make sure that we're offering our patients all the services that they need to have better health outcomes? Rural communities, how do you make sure that your diabetics are coming in for the care that they need? How do we make those connections between our providers that are working in rural communities with their more urban counterparts? How do we reduce that isolation? We had language access, and of course we have stigma. And, in small rural communities, it's very common that if you're referred for a behavioral health problem, you might end up going to the county mental health clinic. And that's a really difficult thing for people, because usually they know people that work at that clinic, and they don't want people to know maybe that they have a behavioral health diagnosis. So how can we mitigate some of those things, right? So we looked at technology, telehealth technologies, because we felt that, we had a lot of issues with trying to get our patients up to specialists, particularly in the urban centers. That's how we focused our work in the beginning. I had a great opportunity to work with Sandeep Krishnan from MedTech. We were partners in crime through this, trying to build a sustainable program that would really allow us to provide that access to patients, and to also help our providers feel more connected to the full healthcare system, to reduce stigma, to reduce transportation problems, etc. So of course we have, the quadruple aim, right? We've always had the triple aim, and now we're worried about provider burnout. And we have seen through our process here at Finger Lakes that we've been able to mitigate a lot of these issues with technology, because it's really changed how we've been able to provide services to our patients, how we've been able to help our staff not have to travel so much, and how we've helped our providers to learn and create great relationships with specialists up in some of the urban centers. Also, we have, we know that, pre-COVID, we knew that technology, although it was in the beginning stages when we started out, everybody thought we were crazy, and that, that telehealth isn't going to happen. This was back in 2007, 2008. And, people thought we were crazy. And we said, we're just going to keep pushing, and we're going to keep perfecting, because we really felt that it was an answer to a lot of the issues that we faced as a healthcare system. And then, of course, now, millennials want to be able to get their care like they get their banking, right? So when surveys have been done, we've seen, and this was pre-COVID, the surveys that were done showed people really were interested in telehealth. They might have had some skepticism, but they were interested to understand how it was going to work for them. So we knew that, and we want to make sure that all of our patients are engaged in their care. And if it means that someone wants to get their care using telehealth technologies, I am all for that. I just want to make sure they get their care, because if we can offer good access, we will be successful, particularly as we start to transition now to a value-based world, away from the fee-for-service world. So telehealth fits so nicely into that, and we wanted to be a part of that. And of course, if we think about what the new world order is, and even pre-COVID, a lot of companies, some of your big pharmacy chains, the insurers, we're all getting into the telehealth business because they saw it as a way, particularly the payers, to make sure that people had a different option rather than just going to the emergency room for care. So they were starting to offer, hey, for $40, we'll take care of that ear infection for you. Just call this number. Well, what happens for us in the healthcare system as providers, they were cherry picking our patients, right? So they were taking those patients from us, and we wanted to be able to see our patients that way. So it really does make a big difference in how your model of care is going to be sustained in the future, because you don't want other people taking all your patients. And if we knew as a health center program, if we didn't engage in telehealth, our competitors were going to. And this was even before the pandemic hit, which had a huge impact on everything, right? So what we also found, we started out we started out with a specialty care model, and we went to specialists. We looked to see who were our biggest referrals out, who did we really need to engage that would make it easier for our patients to get care. And so we used a specialty care model at first, but we expanded that throughout our whole health center program, because we started to see there were so many other great opportunities using technology to mitigate some of the costs and some of our access issues. Patient education, we had staff that were able to work remotely. Even prior to the pandemic, we had people working out of 4 states. Administrative uses, we reduced our travel expenses greatly because of that. We were able to mitigate the cost of some of our provider monthly meetings, because they would all travel to a central location. We stopped all that, and we found out that we were saving about $50,000 a year just for that one meeting a month using technology. So it's been really game changing for us in our health center. And the word of the day, of course, as we move along in healthcare is efficiencies, right? So telehealth really helps us provide that, particularly for our providers. So, what we've said to our staff as we've built our technology capabilities is, we want you to think outside the box. We want you to look at, how can we use this technology to expand things in our centers? How can we use it to get more patient education to our patients? Marketing, interpretation for our Spanish speaking and other language speaking patients. So what we've done is we have in all of our exam rooms at all of our sites now, we have equipment, telehealth equipment, and what we are able to use it for is not only a virtual visit, we're able to use it to provide the patient some education. Hey, you're a diabetic, let's show you some video while you're waiting for the provider to come in. We use it for marketing. We have a COVID vaccine clinic coming up. Please contact the front desk if you'd like to be vaccinated. We are able to call in interpreters if a patient doesn't speak English. We are also able to use it for providers. If we have a mid-level provider, for instance, that's seeing a very complicated patient, they can call in one of the MDs from any of our sites and participate in that visit so that there can be some education going on there. And we use it as well to do soft handoffs to our behavioral health specialist. If the provider thinks that a patient maybe has some issues, and they can say, you know what, let's call in one of our counselors, and you can get to meet them and find out if there's some way we can work together to help alleviate some of your issues. So lots of opportunities. And then, of course, COVID hit, and a lot has changed, sort of, because what happened is everybody turned on equipment because, my goodness, we had to figure out how we were going to get our patients seen in a pandemic. And it really changed how we provided care, all of us, right? But there's some problems continuing through this, because a lot of us didn't do the work that we really need to do to make sure that we have a sustainable program.
So Mary, I have a quick question. Coming into the pandemic, a lot of the healthcare organizations and providers were forced to start up with telehealth. They had to ramp up their telehealth programs and services. As we are coming out of this pandemic, how do you see them coming back once these regulatory waivers are removed, what do you see as the new normal? Because a lot of them, started without putting the adequate processes and workflows in place.
Well, I think that your entities have a really good opportunity to go back to really look at, why do you want to do health? Why do you want to do telehealth in your organization? What are you trying to provide for your patients? We have to go back and look at what do we need to do to weave telehealth technologies into our current clinical processes. We can't, the problem is when COVID hit and we started to use telehealth technologies, people just turned on the camera and started seeing patients. Well, that didn't take into account, how does the nurse do that now? What is her role now? Because now it's different, where she has to learn how to use equipment very quickly. And we haven't done all the work that has taught our staff, this is how you telepresent to a patient. This is how you turn the equipment on. This is what you do if the equipment fails in the middle of a visit. This is what you do if the patient becomes agitated and you need to contact another provider. All those things are really important. And if we were in person, we would already have those things worked out, right? All of our policies and procedures. Well, we have to do the same work through our telehealth programs, and we have to look at how we telepresent patients. How do we work with a provider who's in a distant site? All those things need to be worked on. We have to look at our equipment, our broadband, make sure that everything is in really good shape and up to speed so that we can keep providing that service. Because our patients, now that they're used to this, our patients want to have this available to them. It is not good for every single type of visit, but they want to be able to have this option, and we need to be able to provide that in a safe and effective way for our patients and for our providers as well. So the big thing with telehealth for me, what I learned, we made every mistake in the book. We've been doing telehealth since 2008 and we learned the hard way that you really have to plan. We were lucky that we learned early that was critical. And we also learned early that you have to make sure you bring in the right team. It can't just be a couple people in your organization. You have to bring in a full team that can represent the different parts of your organization: providers, IT, administration, finance, billing, because it's just like any other visit you provide. Everybody has to be involved. And you have to figure out also where are you at in your adoption of telehealth technologies. It's all about change management, right, with telehealth in a new practice, and you need to make sure that everybody's working together towards common goals. You need to understand your regulatory issues. You have to, everybody on the team needs to know that there's going to be a little different workflows involved. And so you want to bring them along from the beginning so that it's a lot smoother of a process. Because the worst thing you want to do is to have somebody get into a visit and something happens and they just say, you know what, I don't like this. I don't want to do this anymore. We don't want them walking away from the potential of telehealth technology. We want to work through that with them. So it really does pay to do your homework. These are just some 4 of the areas that need to be considered when you're doing telehealth. You really need to know what your broadband capabilities are. You have to look at your equipment. There's certain pieces of equipment you want to get that maybe, depending on what you're going to use your telehealth program for, that aren't going to do any good for you. So you got to make sure you understand what equipment's available and what you're going to need for the program that you develop. And then, of course, understanding the legal and regulatory issues in your state. They've changed because of COVID, but some of them are going back. So you really need to make sure that you know what's going on. It's critical that, as I said, that you bring your staff along, different parts of the organization, your patients. What we did when we were working with patients, we would call them and say, well, you're going to do a telehealth visit. Do you want me to help you understand how to use the technology. Do you want to do a mock visit? And it was a little time consuming in the beginning, but our patients quickly, learned how to navigate, and it's been a really great process. So it's been helpful to do that. Also getting your regional, state, and national representatives on board to make sure that some of these waivers that we've all been given through the telehealth, through the pandemic, stay in place. And I know that in New York State, where I am, some of those have been made permanent. So we're pretty happy about that. But there's others that need to go through Congress. And so there's a push for that.
Mary, a quick question. When we talk about staff, I know, and specifically providers, you have providers within your organization who are using telehealth internally, but then you also reach out to specialists across other organizations to deliver care in some of your underserved areas. So can you give us some examples on how you brought in the provider buy-in? Because the providers, from their vantage point, they are doing in-person care as well as now telehealth. What is the value proposition of telehealth for these providers, and how did you bring them over to this new modality of healthcare?
Well, it was interesting because, so let me talk internally for a minute, and then I'll talk about some of our specialists. So internally, what happened is we were bumping along and doing telehealth, and some of our providers were very engaged, some were not. And then what happened is it was interesting because we had a provider who broke her leg, and she was at one of our more distant sites. And I said to our chief medical officer, I said, he was like, well, what should we do? And I said, well, it seems to me you have two choices. You either have to drive out there and see those patients every day because we don't want to cancel patients, or you can use telehealth. We have telehealth down there. We have everything you need to get by, and you can do whichever. And he said, well, no, I'll just drive down there. And I said, okay, that's fine, whatever, And he did that for a couple days, and then he said, you know what, I think I'm gonna try telehealth because this is just a lot of driving, and it just seems like we can get a lot more done using the technology. And so that really changed his perception of technology. And then he came back to his team. And so, as we moved along, he talked to some of the providers. But then also what happened is, we've been pretty focused. You got to keep your productivity up to a particular level, right? We are all in business. And so what we found happening organically is that providers were, now that we had technology everywhere, they were starting to call other sites when they had a no-show to say, hey, I have some time. Is there any patients that you need me to help you with? So it was a way for them to improve their productivity. And so from my perspective, what it really helped me with is to get them much more comfortable with the whole premise of telehealth. So then what we did with all that is we built a whole program for our RNs to help the providers so that the telepresenter, which usually is an RN where the patient is, was very comfortable with the providers so that they were able to have a really good relationship. Because remember, whoever has the patient in the room with them, the nurse or whoever presenting to the provider, they are an extension of your provider, so they need to be as trained and as comfortable with the equipment as the provider is and the patient. So, the big thing is start small. We always do pilots. One of the things we did for our external providers to try to reach out to those specialists were, we would say, hey, we want to do a pilot with you. We want to provide access to our patients. We have this issue. So we would say, we'll give you a telehealth unit to use. We'll teach you how to use it. We'll help you build your skill set with telehealth if you'll give us access to your patients. And we'll actually, for the first year or so, we'll pay for those visits as we would with other specialty care visits if you give us some kind of a discount, because it was worth it to us. Otherwise, our patients either didn't go or we had to drive them. So it was a win-win for all of us. And that was highly successful. We started small, and it also developed into some really great relationships with specialists up in our urban areas which gave our providers the ability to have access to participate in those pilots, be in the room with the specialist while the specialist was seeing their patient. So the learning that went on between the specialist and my primary care provider and the patient was wonderful, because we had providers that started to feel comfortable enough they didn't have to refer out to the specialist as much, which is great for our patients, right? And they also, we had HIV specialists that we were tapping into. Well, because of that interaction with my providers, able to really build relationships with those specialists, I now have a provider who has gone on to become an HIV specialist. We don't refer out a lot of our pediatric neurology children up to the specialist so much anymore, because our mid-levels in particular and our MDs are much more comfortable with those behavioral health diagnoses with children and the medications that go along, because they've had so much exposure to those specialists. But you want to build a strong program, training program. It has to be continual, because you know, you don't do a telehealth visit necessarily every single day, all day. So people have to continue to be comfortable with the technology. You have to really bring your staff along and make sure that they are comfortable. Understand HIPAA. How does that work? And how do you track data through your programming? It's really important that you do all that. You also want to stick to your vision. You don't want one of your providers to come in and say, hey, I want to do a so-and-so with our telehealth technologies, without building a plan and making sure it fits in with what your real issues are and why you're using your telehealth technologies in the first place. It really does pay to make sure that the team has decided this is our goal, and you all work collectively toward that goal and stick with the vision. So for us, we went from you know, I used to say it's like the moon landing program. We went from Apollo, and I kept telling my team, at some point we're going to get to the space shuttle. Broadband was our biggest challenge, of course. It continues today, but it's so much better. But it's been an interesting ride. And now we have just embedded telehealth in everything we do. We see probably about 35% of our visits are telehealth visits. These are some of the programs that we've built that have been really important to our patients in providing care for them. And it's just a part of what we do every day now. And it's been really exciting to be able to see how we've been able to use technology through telehealth as a way to provide care. You know, again, I know we've all done some telehealth with COVID, but you need to really make sure that your program is sustainable and solid. You have to get everybody involved. For instance, you don't want to buy peripherals for your providers without letting them pick it out, because if they don't pick it out, they may not like it, which means they're not going to use it. You really got to have involvement from the whole team. And remember that it's always about the patient ultimately. All the work you're doing, it's about that patient.
Mary, a quick question there. I know you've been a strong advocate of collaboration. Collaboration, you know, between peers, with healthcare partners in the urban areas. But one aspect of collaboration that I found very unique in your program is the academic collaboration, because we have university centers, academic centers spread around in the upstate area. And I know there's one unique example of collaboration that has really helped Finger Lakes Community Health with an academic institution. Can you just elaborate on that and share that with our team here?
Yeah, I can. So we've been working, we were introduced to a program through SUNY Binghamton, the State University in Binghamton. It's a program that focuses their engineering students on helping healthcare entities solve issues across their system. And so we tapped into them, we were introduced to them, and we were able to bring on a master's level systems engineer who came in and has helped us look at all facets of our organization, because one thing we learned with telehealth is, you know, you don't know what you don't know, right? So looking at having this person come in and tell us, I don't want to hear what you did before. I don't want to hear, oh, that's how we always have done it. I want to look at your data and really look at what does your data tell you. And so that's been really instrumental for us. He's helped us look at our no-show data, our, all kinds of different systems that we're working on. He's helped us look at our telehealth data. What is it telling us? Because we do keep a lot of data on that. We keep registries and tracking and our success rates, our failure rates, what is our data telling us? So I would really encourage you all to really be focused on what educational institutions can be your partner. They also have a really well-built telehealth program through SUNY Binghamton through the educational side of life. So really working on providing that type of content for all of us. So it's really important that you team up with some of your educational partners in your region. And so then just to kind of finish up, make sure you let your staff test equipment, buyer beware, make sure you get the right equipment. Your vendors can help you with that, but really keep to the vision and don't, you can buy some really great stuff, but you got to get what you need first, right? And don't try to reinvent the wheel. Reach out to others that have been doing telehealth because you want to start where I'm at. You don't want to start where I started. So it's really important to reach out to other partners that have done some of this work. And keep in mind that, implementing telehealth is a process. It is not a destination. We, even at my organization, and we are pretty far along with our telehealth work, we learn every day. New things, new ways of doing our work with telehealth technologies. It's really, really important that you just keep moving forward. And of course, don't practice until you get it right. Practice until you can't get it wrong. Make sure your staff are really comfortable with what you're trying to do and that they understand how it should happen, because you want them to be comfortable. You want them to, present to the patient a really great image that you know what you're doing, and you want to help your staff be able to do that. And frankly, a lot of people put the equipment before their whole planning process and their program and policies and procedures. All technology it's a very good tool to help you provide quality of care for your patients and to provide better outcomes. So, make sure that you really do all this just to make sure that you have good patient outcomes, because if you track your data, you will find that you will have some better outcomes if you use telehealth appropriately. And I thank you.
Mary, thank you.
Thank you, Mary.
That was incredibly valuable. We have a bit of a adjustment to our, Dr. Talal has joined us. And so your information, your insights are tremendous. Thank you so much. We're very honored to have Dr. Talal with us today, who's used telehealth for a slightly different program and very, very meaningful program. So with that, I will turn things right over to Dr. Talal. Thank you, Doctor.
Thank you very much. And Mary, that was very nice. And so I'm going to give you a specific instance. And if I can build on a couple of points that Mary made, know your vision, and engagement of the entire staff is very important. And I think lessons applied in the work that I'm going to present, which is really very specifically building telehealth capacity for difficult to engage populations and what we're calling patient-centered hepatitis C telemedicine model. And this is a 5-year grant that I wrote at the end of 2015 and was funded by the Patient-Centered Outcomes Research Institute. And so the vision was well described and down to the number of people we needed to recruit. So I will advance the slide. Okay, so these are my disclosures. So we've built through this grant opportunity, we built a statewide telehealth collaboration model, which uses HCV as a use case. And it primarily affects difficult to engage population because who has hepatitis C? So these are primarily substance users. And just a word about hepatitis C, it's the most common cause of, or the most common bloodborne infectious disease. Prior to COVID was the leading infectious disease cause of death. And because the primary population that has it are substance users, they're stigmatized when they go, or can feel stigmatized when they go to places that Mary described, FQHCs. And so one of the proposals that we made, or the thoughts we had, was that we could bring the treatment to them by virtually integrating the hepatitis C provider directly into the opioid treatment program. And it not only facilitates encounters from the standpoint of the stigmatization. Substance users feel these, by and large, and view these programs as communities. And so we were able to do that. And also it removes the broadband access issues, because these programs are distributing medications and providing healthcare services. So by their nature, they have to have adequate broadband and computer access. I'll discuss some of the challenges as to the statewide telehealth implementation. And finally, some of the issues we've had to do in order to gauge substance users and OTP providers. So a word about hepatitis C, just to reinforce what I just said. It's a virus that infects the liver. It's spread through infected blood. Substance users and baby boomers are really the primary populations. It's unfortunately been a consequence of the opioid epidemic, has been a recent increase in hepatitis C cases, and untreated can lead to liver failure and liver cancer. And it remains the #1 indication for liver transplant and also liver cancer, and caused about over 17,000 deaths in 2017. So why don't people go to places like FQHCs in order to be treated when they have hepatitis C? And so it's really describing what we consider to be a difficult to engage population. When you ask people, and we've done this, that reference was a paper we published about 7 years ago, 78% of HCV infected patients at addiction treatment centers are willing to get treated, but only 5% will actually go for treatment. And there are a variety of real world barriers that prevent them from going. Lack of knowledge about the virus, lack of stable employment, unpaid time off from work, competing priorities, unstable housing, domestic violence situations, limited or no insurance, and stigma associated with substance use, we find to be overwhelmingly a very important aspect. And what we've been able to do is to develop this patient-centered integrated HCV treatment model. So using patient-centered telemedicine, we integrate HCV care in the familiar and comfortable setting of the substance use treatment program. And so why focus on opioid treatment programs? Well, up to 70% of people at such programs have Hep C, because it's spread by injection drug use, heroin. That's why they're in the opioid treatment program. But heretofore, the vast majority of programs have really lacked on-site HCV screening and treatment. It is important to note that over the last 5 years, there has really been a revolution in hepatitis C treatment, where now almost everybody can be cured. 2 to 3 months of treatment is necessary, and these are all oral medications. So it's no longer, though some of you may be aware that we used to treat hepatitis C with an interferon, which was absolutely horrible for treating this entity. It made people feel like I would hear, it's eating my methadone. So the symptoms of interferon side effects are similar to opioid withdrawal. It exacerbates mental health problems, which is exactly the opposite of what you want to be doing in this population, which has a lot of comorbid mental health issues. So really, this HCV treatment revolution is one of the reasons that it has really made telemedicine a perfect opportunity, also because you don't need to see the people in person. As a practicing hepatologist, there's not much I do in my hepatitis C patients if I see them in the clinic or I see them virtually. And so this patient-centered integrated HCV treatment model has really, obviously you need standard internet access, which we've accomplished by placing it in the substance use treatment facility. It can integrate behavioral and mental health care, and it provides remote patient engagement. So our model is illustrated here, which is really quite simple. Patients are screened for hepatitis C at an opioid treatment program. Those who are HCV positive undergo a patient-centered integrated HCV treatment model. They have a patient and a nurse practitioner at the opioid treatment program sit together. Patient is evaluated, undergoes an evaluation via video conferencing, and that's me showing actually a model of the liver, which is one that we use. Right here, I keep it very close, but basically shows the liver and shows how hepatitis C progresses. We found that to be very useful. And we were able, because these programs are dispensing methadone, we were able to leverage that so that hepatitis C medications are dispensed with methadone, and this is repeated until patients are cured. And some of the anecdotal evidence that our model has engendered is that it builds trust between the patient and the provider. It expands and develops patients' sense of healthcare ownership. Patients also have an expanded sense of self and purpose, and willingness to engage in greater care and lifestyle. So, I've had people who, after they're cured of hepatitis C, feel better. Their quality of life improves. They have more energy. They get jobs. They get off disability. Substance use goes down. And so these are some of the ancillary benefits that can accrue from treating this population. And so in a pilot study that we published a couple of years ago, we enrolled 45 patients at one site. There was on-site medication dispensing that increased adherence. 45% were cured via telemedicine, and that's in the first paper published in Clinical Infectious Diseases. And when we asked patients, conducted a survey, 95% recommended telemedicine approach over in-person referral. And that's covered in a paper published in Telemedicine and eHealth around the same time. The data from the pilot study were used, as I said, to develop an application that was subsequently successful with the Patient-Centered Outcomes Research Institute. So they provided 5 years of funding from March 2017, and we've completed enrollment, thankfully, 2 weeks before the COVID pandemic hit. And we enrolled over 600 patients, 12 sites across New York State, covering most metropolitan areas, 6 upstate and 6 in New York City. And in our case, we find, similar to the last speaker, that telemedicine removes time and places obstacles from delivery of high-quality, cost-effective healthcare, and really permits providers to treat statewide from the same location. So I can sit in my office in Buffalo, where I'm sitting now, and see a patient in Brooklyn, see a patient in Syracuse, and see a patient at a site 2 miles away here in Buffalo, all in the same morning. And so it's just efficiency in scheduling. And we published a paper a couple of months ago in the Journal of Biomedical Informatics entitled A Framework for Patient-Centered Telemedicine Application and Lessons Learned from a Vulnerable Population, that really describes the work that went into developing the statewide telehealth system. And so this is the graphical abstract, which I'll cover in a second in some detail. But basically, we use something called the socio-technical system, which is an 8-domain scale that describes telemedicine, that breaks down the steps required in telemedicine implementation. And 4 shown in the orange on the outside of the oval are really those that I think have really been solved, at least in well-established telemedicine systems. I mean, Mary discussed some of the needs when developing a system from the ground up, but the infrastructure, for example, the equipment is fairly standard. The facility, you need to think about, you need adequate broadband access. You need a camera and a computer and audio visual. Of course, there are external regulations, and you need credentialing. And we discussed having the entire team on board, the patients, the clinical staff, and the stakeholders. And I'll have more to say about that in a minute. But where I really think we need to think about are especially clinical content, interoperability. When you're developing a system from the ground up, you, as a clinician, for me to be able to do that, sit in my office in Buffalo, the problem was that I needed to have credentials at all of those places, and I needed to be able to use 5 different EMRs, because every site uses a different EMR system, and to be able to access that EMR. And so as a proof of concept, yeah, it works, but we've got to work on the ability to share information. We use faxes. I mean, the study paid for people at the site to print out paper and fax it to me. And so why are we using 1980s technology to deliver 2020 healthcare? Is really an interoperability problem, so that I can sit in my office and be able to gather data on a patient being seen at someplace else. Internal organizational features, of course, you need to have the system work, and I think that remains a work in progress. Measurement and monitoring, I think, are key to sustainability. Development of ENM codes, evaluation and management codes specific to telemedicine. How do you define a quality exam or a quality interaction? That's another one. Who should set those standards? Professional societies, the ATA, the American Telemedicine Association, HRSA, governmental bodies. I mean, this is something I think we, as members who are interested in this, and all of you attending, really need to advocate on. And of course, then workflow and communication. So I think these remain what I consider to be the research gaps. And of course, then there are social determinants of health. We obviated many of them by bringing the treatment in the methadone treatment program already. But if you want to expand outside, these are certainly things that one needs to consider. And so a couple of lessons learned. Interoperability, you need to have a detailed understanding of the regulations, the licensure, measurement of telemedicine quality, evaluation, and one needs to, when developing telemedicine for a difficult to engage population, one needs to build trust and confidence with patients as partners, and hope to minimize the patient burden through simple scheduling systems and integrated appointments.
Dr. Talal, I had a quick question. So technology obviously is the connecting point for the patient and provider in a telehealth environment. What aspects of technology did you look at to make that engagement easier, both from a provider standpoint and from the patient standpoint? Because you also talk about trust. So what aspect of technology brings all this together for a good experience from the patient and provider standpoint?
So I'll answer. I think you know the answer to that question already, because you helped me set up the system 6 years ago. But based as a consultant, Sandeep was involved in visiting each of these sites and making sure that that the telemedicine audio and visual connectivity worked well. And at the time, he had recommended Zoom, which we used. And by a cloud-based system, by purchasing a license, that gave us control over all of the sites, and we had plenty of portals, so all of the providers at all of the sites could be listed on the license, and it worked very well. We also had backup systems. So I think that technology, audio-visual connectivity has really been solved by a cloud-based system. We need to solve the issue of clinical data content at fingertips. So in the last 5 minutes, I'll just say a word about engagement of both patients and staff. And this is a paper we just actually published a couple of weeks ago, entitled Facilitating Engagement of Persons with Opioid Use Disorder in Treatment for Hepatitis C, Stories of On-Site Case Managers. So in terms of a facilitated telemedicine system, the case manager at each site really plays in a very important role in terms of being the conduit for the patient, the local provider, and the external provider. And so at each of our sites, we have people who've been very dedicated as part of this process, and they're listed here. And we ask them, what were some of the interesting stories that you heard, or what were some of the aspects that you had to overcome in order to gain trust of patients? These are, as I said, patients who feel stigmatized if they go to conventional healthcare settings. Get out of my emergency room. In the 1990s, Gomer was one of the phrases we heard when I was in medical school. And so what these programs, at least the ones participating, and of course this is not universal to all substance use treatment programs, but is that there's a feeling of trust in the treatment program, which we were then able to leverage, or the case managers were able to leverage, in order to build trust with the patients, to assist them in overcoming their competing priorities, and to develop personalized care. And sometimes this was a month-long or year-long endeavor. In other words, there may have been people who said in the first wave, I don't want to be in 2017, I don't want to be part of the treatment right now. Next year, they're willing to be treated. And what we asked these people to do in our context was really to first and foremost be part of a research study. And these, again, are places where research has not conventionally been conducted in many sites. To engage in clinical care via hepatitis C, half the patient's usual care went for off-site referral, the other half engaged in telemedicine. And so this case manager really was what we consider to be the builders of the bridge of trust between the patient and the telemedicine provider. And what we found was that, and perhaps most importantly for the future of virtual care, was that trust was extended through the virtual apparatus. So I didn't need to be sitting there in the methadone program to be embraced and accepted by the patients. I was accepted virtually by the patients as part of that program, even if I was sitting anywhere else. Physically, location didn't matter. And so what that enables, I think, and sort of as a proof of concept, that telehealth enables healthcare delivery to difficult to engage populations, can be used to bridge the digital divide. Of course, there are whole other issues about broadband access and other things that are outside the realm of this presentation. But substance users can develop trust and confidence in a telemedicine system, and it can be used to integrate behavioral and medical treatment. Statewide telehealth network is feasible as a proof of concept, and there are challenges for clinical implementation are, I think, really this interoperability issue as a clinician, of course, regulation, and ultimately the people that pay me, or who are responsible for making sure I stay out of, I don't get sued for malpractice, are going to be interested in probably telemedicine specific measurement codes, standards and management codes. But I think that's work for a different realm. So I'd like to thank you for the opportunity to speak to you today. And it's great pleasure to be able to, and I'm happy to take any questions if there are any.
Thank you, Dr. Talal. Trying to get Mike back here. Bear with me.
Sandeep, did you have any questions?
Yes, actually, Dr. Talal, beyond the clinical interactions between, in your Tele-Hep C program, what are the other ripple effects? What are the other opportunities of collaboration, data collection and analysis, developing research opportunities and papers? So can you give us an overview of some of those things that have come to play after your as a part of your telemedicine program?
Sure. So we are working on other manuscripts that are current. We really want to provide a comprehensive overview of this model. And so we are looking at some of the issues in terms of resource allocation. What does it cost to patients, or how costs, how to, what from the patient point of view, what are some of the cost savings? Of course, the primary outcome of the study, which we will be publishing later this year. Satisfaction with healthcare delivery. We have questionnaires. We're doing patient and staff interviews at the moment, looking at some of those questions. And ultimately, reinfection. And I really want to thank Picori for the support, and that of each of the provider, the PIs at each of the sites, as well as the people who were included on each of the manuscripts, because they really played a role. They should be acknowledged, and they've really played a role in terms of sustaining this program.
And what about the New York State Hep C collaborative that came out of this initiative?
Yeah, so we've been able to, we had a follow-on grant or funding from the CDC through the New York City Department of Health that enabled us to set up a New York State telehealth work group. It meets every other month at the moment. We just had our meeting right before this one. And the goal of that work group is to expand access for treatment of hepatitis C via telemedicine. And in fact, there's a lot of work now going on with hepatitis C elimination. The Nobel Prize in Medicine was given for hepatitis C last October. And Biden put out an executive order yesterday endorsing Hep C elimination nationwide. And so we had a discussion. We had two states, Louisiana and Washington State, have really been at the forefront of Hep C elimination. New York State has started, but it got a little bit postponed we actually had in 2018. I served on Cuomo's Hep C elimination panel. But Washington, so we had a presentation from a colleague in Washington State and a colleague in Louisiana about their Hep C elimination programs statewide at 10 o'clock this morning. So
thank you, Dr. Talal. Chris, are there any other questions from the audience?
No, this was, I think, a comprehensive presentation by both Mary and Dr. Talal. And we do have Mike back. Mike?
Yes. Thank you for that. So Dr. Talal and Mary, thank you so much for sharing your experiences. I think we've come away with the intent, starting with defining the healthcare delivery that you intend to take advantage of or leverage through telehealth or telemedicine. So I would like to invite all of our participants to please use the URL, the email address, reach out to engage either Aspire or MedTech Interlink on receiving a recording of the session or further follow up on how we can help you to define the funding sources, the technology, or a little bit more detail on defining that delivery service. And it's been a wonderful experience. I think it's worth pointing out that both Mary and Dr. Talal have developed these tools in a need for their community and their patients. And we have been doing this long before, before the pandemic. And so I think it's much more useful now, but clearly demonstrating that there's an abundance of voids that can be met through a telehealth or telemedicine program. So with that, I'd like to thank our presenters and thank all of our attendees for joining.
Thank you for the opportunity.
Mary, Dr. Talal, thanks again for your insights and also your valuable time. We appreciate it.
Thank you.
Thank you.
Appreciate it.